Okay. We call Mr. Deco for trapezium metacarpal total joint replacement as an alternative to trapeziectomy depends on Trapezium 8 retrospective study of 67 patients. Mr. Deco?
Good morning, dear colleagues. Can you hear me?
Okay, we can hear you.
Thank you. I'm very glad to have the opportunity to present a paper about trapezium metacarpal prosthesis as a therapeutic alternative to trapeziectomy. It's a prospective study I've made with Professor Barbier and Professor Lebouton, one of our assistants at the Clinique Universitaire Saint-Luc in Brussels. This paper has been published in the Antidote Rehabilitation in March.
And your sound is not very good.
Okay, maybe I could change something. Is it better?
Yes, it's well better.
Okay. Okay, so next slides. So as you all know, in case of conservative treatment without improvement, surgery is indicated. Trapeziectomy with interposition or trapezium metacarpal prosthesis is the two classical surgical options. Some comparative prospective studies have shown better results in terms of strength of polydigital pinch, range of motion, postoperative pain, early recovery, and the rate of is sorry. So as I say, the main complication reported on the trapezium metacarpal is on the trapezium metacarpal, on the trapezial component, sorry, such as instability, aseptic loosening, and trapezium fracture. The trapezium should have a minimal height to accept cup in optimal position to avoid fracture when impacting the implants, and the minimal size advance in the literature is of 8 millimeters. So we ask two questions. So what percentage of our patients operated with trapeziectomy were eligible for metacarpal based on trapezium height, and could Eaton Littler with arthrosis classification predict the radiological height of trapezium bone? So we reviewed all of our patients that underwent trapeziectomy with interposition at Clinique Universitaire Saint-Luc from 2013 and 2018 by two operators. 80 patients were in the database, and 12 of them didn't have interpretative radiography according to our selection criteria, which were to have an AP and lateral Kaplan-G view on the database. One other patient was excluded because treating STT arthritis. And as we can see, we have stage 1, we have 0 patients, and stage 2 of with arthritis is those numbers. Just for information, the mean age was 62 years, and majority of women. So for the methodology, we measure trapezium height on Kaplan-G, AP, and lateral radiographic view. As we can see on the mean by Eaton Littler stages, we objective decreasing from stage 2 to 3 to stage 3 to 4. And especially on the Kaplan-G lateral view, we can objective mean below 8 millimeter. This is just to say our reliability of database has been proved by calculating intra-interclass correlation coefficient we can see that the both index are good. Then we perform analysis of variance by ANOVA test. On this table for the AP view, we have shown that there is a significant decreasing of trapezium height according to Eaton-Littler stage. And it's the same for the lateral view. There is a decreasing of the trapezium sign, which is significant also. So in the literature, we found that the several authors recommended the trapezium heights of 8 mm in our series, according to both trapezium height AP and lateral views. 86% were eligible for prosthetic replacement. So we can discuss about the best cup position to avoid complications such as dislocation. This optimal position has already been defined by other authors, and the cup should be centered in the trapezium bone and should be strictly parallel to the proximal articular scaphotrapezial surface. And as we can see on this table on the right, the cup depth on the prosthesis available on the industries is from 5.4 to 7 millimeters. And so according to this, we should avoid prosthesis in late stage 4 because of too small trapezium height and risk of fracture when impacting the cup. And so in conclusion, trapezium metacarpal prosthesis is possible on the majority of trapezium bones, and Eaton-Littler's classification influenced the height of the trapezium. And we must be careful in stage 4 indication because of too small trapezium and the prosthesis. So it's a good alternative to trapezectomy if sufficient preoperative trapezium height and meticulous techniques. Thank you.
Thank you very much, Bastien, for this nice presentation. I call now Leo Shish. Okay, for long-term survival of ball and socket trapezium metacarpal prosthesis for osteoarthritis. Leo, up to you. Oh. Your sound is not activated.
Okay, is it good now?
Yes.
Okay. Hello, everyone. Thank you for giving me the opportunity to present this work on long-term survival of ball and socket trapezium metacarpal prosthesis for first osteoarthritis. So as you know, trapezium metacarpal osteoarthritis is very frequent, especially in postmenopausal women. And as we discussed, the two surgical options nowadays are trapezectomy and trapezium metacarpal prosthesis. So we did a retrospective study. The objective was to evaluate long-term survival rate of ball and socket trapezium metacarpal prosthesis. We did this study on 340 trapezium metacarpal prosthesis operated between 2001 and 2016 in our department in Montpellier. It was mostly women, and the mean age was 65.7-year-old. 3 prostheses have been implanted. It was mainly Maya from Group Lepin, and also Roseland and Arp. It was mainly anterior approach and 74%. And in postoperative, they had cast for 3 weeks. The evaluation was done by self-questionnaire, including pain, global satisfaction, cosmetic satisfaction, quick dash, and opposition temp. And X-ray were done and look for sign of early loosening or osteoarthritis of the other joint. So on 340 and 340 trapezium metacarpal prosthesis operated on, we had 10 disease, and 29 patients were lost to follow-up. The other one were contacted by phone. It was 245 patients. 16 of them had already been operated for a surgical revision of trapezium metacarpal prosthesis. And the other one received a questionnaire and X-ray prescription. So we received 225 questionnaire and 200 X-ray. The global survival rate was calculated on 294 trapezium metacarpal prostheses, clinical assessment on 225 prostheses, and the radiological assessment on the 200 prostheses. The median follow-up was 6.3 years, and maximal follow-up was 17.3 years. The clinical results were very encouraging, with the close to 90% that were satisfied or very satisfied. And as you can see, the median quick dash was 20 on 100, and with a return to work about 2 months. Considering the surgical revision for the main criteria for the survival rate, the survival rate at 10 years was 90.8 years and 95.9 at 5 years. So the fail rate of the prosthesis was 5.4%. Considering the complication, we found 14% of complication, minor complication, mostly complex regional pain syndrome and Decaven stenosynovitis, which the treatment was medical for 70%. Concerning the major complication, we found 7.8% of complication, 3% of dislocation, and 3% of loosening. And as I said, we had 5.4 revision. So when we interested in the major complication, and especially the dislocation, we found that most of the dislocation occur on the first year and were due to inadequate cup orientation. Two delayed dislocation were due to polyethylene wear. And it's interesting to note that all dislocation needed surgical revision and not only reduction of dislocation. And considering the loosening, all the loosening occurred after 6 years of trapezium metacarpal prosthesis, and 5 were asymptomatic and only found on the X-ray assessment. When we look for the literature, we found many studies in ball and socket implants, but few include more than 100 implants. And the biggest one is the one from Martin Ferrero in 2019. And few include people with more than 10 years of follow-up. Our results are quite similar than the literature, with a survival rate that is slightly above average. When we look for the complication, we also found that the 2 major complications are dislocation and cup loosening, with some rate that are slightly under the average in our study. We already discussed about trapeziectomy versus prosthesis, but there are few comparative studies and 2 only prospective studies that found significant superiority of the prosthesis in pain, strength, mobility, satisfaction, and recovery time, but only with one with 1 year follow-up and one with 6-month follow-up, and with no complication range difference. And as we saw in the presentation before, it can provide best MCP correction of the hyperextension. And in case of wear and loosening, a secondary trapeziectomy is still possible. So in conclusion, ball and socket trapezium metacarpal prosthesis has a satisfactory long-term clinical result with a survival which is more than 90% after 10 years. The complication rate is limited and principal concern the trapezium. And as we just see in the presentation before, the optimum positioning of trapezial cup is very important. It seems that it can be more easier with the lateral approach and with the use of fluoroscopy in perioperator. And for the future, we will see if the dual mobility can improve the long-term survival, and maybe we will find long-term prosthesis superiority versus trapezectomy. Thank you for your attention.
Thank you very much, Leo. It's a very nice presentation that demonstrates that the survival rate of trapezium metacarpal prosthesis is similar to those of total hip prosthesis in GREED series. It's a very nice work. Thank you very much. I call now Joris de Ring for the to treat about capsular release. That's an important point in trapezium metacarpal surgery. Joris, thank you.
Okay, thank you, Pascal. So we have already seen that capsulo-ligamentous structures are essential for the function of the normal trapezium metacarpal joint. But now we'll have a closer look at the influence of the capsule and release of the capsule on the range of motion and the stability after replacement of the trapezium metacarpal joint with a prosthesis. So dislocation remains one of the most important complications after trapezium metacarpal replacement, and the reported incidence in the literature is around 5%. And the reason for an unstable implant can be multifactorial. It can be that the position of the components is not optimal, but there can also be a problem with the soft tissues. So when the tension on the soft tissues around the trapezium metacarpal joint is not high enough, they do not provide enough compressive force to hold the ball in the socket. It can also be that the soft tissues are not well balanced and that they cause tethering in certain positions of the trapezium metacarpal joint. This can be explained by the different biomechanics of the normal trapezium metacarpal joint and the prosthesis. We have already seen today that the normal joint has a double center of rotation, one in the base of the metacarpal and one in the trapezium. But after implantation of a prosthesis, this is all simplified to only one center of rotation in the trapezium. The ligaments are shaped to stabilize a normal joint, so they can potentially destabilize a prosthesis because of the different biomechanics. And we can expect that potentially the biggest problem will be encountered with abduction-adduction, because the center of rotation for this motion has been proximalized from the base of the thumb metacarpal towards the trapezium. And therefore, Pascal Ledoux has already suggested to release certainly the intermetacarpal ligament between the base of the first metacarpal and the second metacarpal when performing a trapezium metacarpal joint replacement. It has also been advocated not to only release that ligament, but also to perform a complete capsular release around the base of the thumb metacarpal. In a series of myoprostheses with a complete capsular release, there was a dislocation rate of more than 9%. Even more than half of the dislocations occurred in the first postoperative week while the thumb was immobilized in a cast. So can it be that capsular release can cause initial prosthesis instability? So that was our research question. And to examine this, we performed a study on cadavers, 7 fresh frozen forearms. The tendons of the important intrinsic and extrinsic thumb muscles were all loaded to simulate physiological muscle tone. In this setup, we compared 7 conditions for the trapezium metacarpal joint. The normal joint, then the normal joint after complete release of the joint capsule. Next, we resected both articular surfaces of the trapezium metacarpal joint with a double oscillating saw blade of 5 millimeters. And this gap of 5 millimeters corresponds exactly with the length of a medium offset neck of the RP prosthesis. So when we resected 5 millimeters and we inserted this prosthesis, the length of the thumb was perfectly reconstructed. And then next, we progressively lengthened the trapezium metacarpal joint by using progressively longer necks with a 2 millimeter increments up to 8 millimeters of lengthening of the thumb and the trapezium metacarpal joint. We used an electromagnetic 3D motion tracker system to measure the motion of the joint. This is a really accurate system. We measured the active range of motion of the thumb by simulating this by loading the appropriate muscles. And finally, we also subjected the trapezium metacarpal joint to a distraction test by pulling on the thumb with a force of 1 kilogram. This to simulate the push-pull maneuver that many surgeons use during surgery. Here you can see the results for motion. So on top is the flexion extension graph and below is the abduction adduction graph. The average arc of motion is represented together with a 95% confidence interval. From the left to the right, you can see the result for the first the native joint with an intact capsule, then the normal joint with capsular release, and then the trapezium metacarpal implant with progressively longer necks. In green, you can see that we measured an average flexion extension of 41 degrees and abduction adduction of 49 degrees. And this corresponds well with the results of normal motion that are discussed in and shown in literature with other measurement methods. So for us, this was a good way to check the reliability of our setup. As you can expect, you can see a trend for increased motion when the capsule of the joint is released, but the difference in motion between a normal joint with or without capsular release was not significant. It is only after implantation of a trapezium metacarpal prosthesis that there was a sudden increase in range of motion. With a gradual lengthening of the prosthesis neck, the range of motion progressively decreased again. In the flexion extension curve on the top, you see a zone that is marked in red. And these are the only statistical significant differences between the measurements when compared to the normal joint. So the highest motion is seen with the trapezium metacarpal prosthesis with capsular release, but that is not lengthened when compared to the normal joint. And in this particular situation, the average range of motion was 66 degrees for flexion extension and 62 degrees for abduction adduction. The upper margin for the 95% confidence interval is around 75%. So this is still less than the range of motion of many trapezium metacarpal prostheses. For example, a non-constrained RP prosthesis with a medium neck has a range of motion of 97 degrees. Progressive lengthening of the trapezium metacarpal prosthesis will again decrease the range of motion, but it will never be stiffer than the normal trapezium metacarpal joint. These findings show us that capsular release increases significantly the flexion extension, but not beyond the possibilities of most prostheses. But beware of suboptimal component positioning, hyperlex patients, and a traumatic event at the thumb. Now we'll have a look at the distraction measurements. After capsular release of the normal joint and implantation of a prosthesis, there is a significant increase in longitudinal laxity. And when the prosthesis is progressively lengthened, the laxity will decrease again, like in the motion graphs. The most prostheses use a small diameter head of 4 millimeters, with the consequence that a distraction on the thumb of 2 millimeters or more will pull the head out of the safe confinement of the socket and the liner. And this can lead to a potentially unstable situation. According to our measurements, lengthening the trapezium metacarpal joint by more than 4 millimeters is required to reduce the mean distraction within the safe zone of less than 2 millimeters. So it's only when the trapezium metacarpal joint was lengthened by 6 millimeters that the distraction distance, when you pull on the thumb with a force of 1 kilogram, falls within the safe zone of 2 millimeters or less of distraction. This can explain why Jean Roubaud measured in his clinical series that he had a mean postoperative thumb lengthening of around 5 millimeters. So this corresponds approximately with our findings in the cadaver lab. But probably the distraction will diminish with postoperative scarring. Are there any drawbacks when you lengthen a trapezium metacarpal joint for 5 or 6 millimeters? Jean Roubaud did not find an increased incidence of decurvent tendinitis, but it seems reasonable to suggest that a certain amount of lengthening will increase the tension on the tendons and the muscles that cross the trapezium metacarpal joint, and that this can possibly also lead to stiffness in the metacarpophalangeal and the interphalangeal joints of the thumb. I do not know of any study that has examined this yet, but it can be an interesting topic to discuss later on. And theoretically, we can decrease the amount of lengthening to prevent prosthesis dislocation with traction by using a constrained cup, using a larger diameter head, or maybe it can be an idea to spare or suture the non-tethering ligaments like the dorsal and palmar ligaments, because the center of rotation of flexion and extension remains in the trapezium, both in the normal joint and after implantation of a prosthesis. Thank you.
Thank you, Joris, for this, as usual, very nice presentation and very nice study.
Thank you.
So I call now my friend Bruno Lucier for what I use total thumb CMC1 joint arthroplasty.
Yes, thank you, Pascal. Thank you, Anne, again for the invitation. There are some reasons in my choice of TCA for the surgical treatment of CMC1 arthritis. Okay, first of this reason is the anatomy. Why removing the trapezium and 3 or 4 joints when we can conserve them? We avoid so doing shortening of the thumb and returning, as said Joris, to orangutan thumb. We avoid hyperextension of the MP joint and leave tendon intact. It's a joke, this picture, but I always remember with emotion the name of Surgeon Charley after a remotion of a head and neck on the hip. My second reason is the biomechanics. Total prosthesis provides a point of support between first metacarpal and trapezium, as said Pascal, and is the most logical solution from a mechanical point of view. It allows an optimal function of extrinsic and intrinsic muscles around the thumb, and the balance socket principle allows normal opposition. Third reason, the improve, excuse me. I tried to, okay. Third reason, the improvement, excuse me. Third reason is the, okay, the improvement of the prosthesis. All types of TCA are based on balance socket principle. Since first types in early 70s, certain types of TCA have disappeared for bad results or commercialization problems, you know that. Actually, most of the prostheses disponible are improvements of initial concepts. Last of them was the double mobility principles. And the recent analysis we find in literature concern only the 6-7 types of prosthesis. Fourth reason, is clinical. First reason, as I said, is clinical. First of all, the patients are very satisfied or satisfied by this kind of surgery, not depending on the type of prosthesis. Then, after, the delay of recovery is rather fast. The patient is asked to mobilize the thumb after removing the stitches and may begin light activities with an intermittent wear or splint. Normally, you see this patient is using his right thumb after 3 weeks. So third, the quality of clinical results. In a recent analysis of a continuous series of more than 100 patients with a minimum of 3 years follow-up, we analyzed different items. Pain relief, as you see, is nice as for trapeziectomy. We also note a nice improvement of the quick dash around 20 as for other types of prosthesis. It was the same thing with the range of motion. It's very important because prosthesis gives nice results in terms of abduction, antepulsion, also in terms of retropulsion. It's possible for the patient to hold their hands on the table. The K-pinch improves significatively with the majority of patients between 2 and 5 before surgery and 6 and 8 after surgery. The fourth reason is the analysis of literature concerning the recent prosthesis with a long-term follow-up. And this analysis, as you can see, is rather hopeful. The level of survey is, in the majority of cases, better than prosthesis of the big joints, as said Pascal. It is difficult to compare the techniques of surgery in CMC1 arthritis. There is few analysis. As you can see, early results are better for Ulrich Winter, no difference for Vandenberg, but better results for recent series for the prosthesis, but in a few articles. I can hear you. What about complications? For certain types of prosthesis, the level of failure was very important and unacceptable. This level has strongly decreased with most of the 6-7 types of prosthesis still in activity, we could say. Dislocation, as Leo said, has quasi disappeared. And now with the double mobility prosthesis, the recent study shows there is no dislocation anymore. Loosening around the cup remains a problem. But we can observe an improvement, as you can see, between older and recent series, must be probably to the types of prosthesis and the technique. For me, wear of polyethylene after several years remains also a problem, especially for active patients, as we will see in another communication. And new types of polyethylene tip crosslink will be probably soon disponible. The other complications are uncommon, and sometimes, as you can see, periprosthetic ossification is a good thing for the patient because there will be no wear of polyethylene in this case. In consequences, the rate of revision has decreased and is comparable to the arthroplasties of the big joints. Main reasons are actually first loosening of the cup, and we have to wait long-term results of double mobility prosthesis who theoretically diminish the stress between cup and bone. Second reason is wear of PA, and modification of PA, as I said, should modify this problem. Revision of a TCA is not surgically a big challenge. Depending on the remaining trapezium, we may change partially or totally the prosthesis or do a trapeziectomy with nice results. Another reason is the cost of the prosthesis, as we can see. The cost of this prosthesis is rather high depending on the country, but the day loss before returning to work for patients always in activity are also expensive for the society. And the few analyses comparing return to work between prosthesis and trapeziectomy, difference is important, as you can see, and is very expensive for the society. Alors, our indication now to conclude for people over 60, 65, I will tell you in another communication for younger people. So we have to hear the patient with what he's doing in terms of sports and hobby. He's not, if he's retired, what he wants, fast return to sport activity, and most important, what he'll be able to do and not to do. And the second analysis is the X-ray, the trapezium, his size, deformation and quality of bone, and the state of STT. For us, our best indication is first clinical, all activities. There is no limit for prosthesis after 60, 65, and the X-ray may modify this indication. It's addressed only to 2, 4, 3 Dell stage classification we are using. So I think I finished. Yes, so thank you very much.
Thank you very much, Bruno, for this nice presentation. Now, I know why I place prosthesis. Thank you.
TMC prosthesis complication. This is a systematic review of prosthesis. Is the first generation until the third generation, with a mean failure rate of 12% at 3 years. Failure here corresponds to revision or removal of prosthesis. Infection and metal allergy are very rare. Dislocation are in order of 12%. Loosening of the prosthesis represents 55% of the failure. In case of loosening, 84% are at the level of the cup. The cup is the weak point of the prosthesis. This is the result of more recent publication. The percentage of dislocation is from 0 to 13%. Most of the dislocation are before 1 year postoperative. Double mobility seems to bring a better stability with less than 1% of dislocation. Loosening, principally of the cup, is from 0 to 10%. Most of the loosening are rate complication. The percentage of revision varies from 0 to 25%. In the publication of de Martinet, it concerned 8 cases on 21 cases during the first year. So there is a learning curve of 30 cases. The midterm survival at around 5 years is between 90 and 100%. The long-term survival at minimum 10 years is between 85 and 95%. The article by de Martinet gives some indication on the survival rates at 15 years of 80%, and this is not so far from the 15 years total hip survival between 84 and 88%. The long-term survival of the TMC prosthesis is the first criterion of a prosthesis. And if you want to go on in Belgium, we need a national registration. The TMC prosthesis is a technically demanding procedure. Most complications within 1 year, especially the early dislocation, are correlated to technical errors. There is a learning curve of about 30 cases. To speak about complication means to speak about the surgical techniques to prevent this complication. One of the tips and tricks of the operation is the exposure of the TMC joint. We need a panoramic view of the joint, and we need to see the 2 arms of the trapezium. To get this large exposure, it seems easier by a dorsal approach. All the ligament of the basis of the first metacarpal must be sectioned with a complete capsular release and the possibility to mobilize to push down the first metacarpal. For this, in the intermetacarpal, Professor Daniel Heron, our fellowship president, performed a resection of the dorsal capsule to get a better exposure. The cut of the first metacarpal has to be perpendicular to the axis of the diaphysis. And in some difficult cases, as in the Z deformity, we need to remove more than 5 mm to be perpendicular. On the right, see an example of a bad orientation of the stem. We need to use the fluoroscopy. The size of the stem, we need to implant the biggest size of the stem to avoid the subsidence of the stem in the diaphysis. The revision in this case was to change the size of the stem. On the left, a dislocation before 1 year on technical error, the palmar of Arthritis. On the right, a late dislocation of our old prosthesis after 19 years on a medial Arthritis with a came effect and dislocation. We can use the stem holder to verticalize the first metacarpal for a better access to the volar osteophyte. Here, a publication, or there's only 3 publications of the double mobility. You have a publication of third edition of 200 movies, with a survival rate at 5 years of 97% and a rate of dislocation of 0.5%. It seems that the complication of dislocation is solved with the double mobility, but still the problem of loosening of the cup and the polyethylene wear. There are 5% of incorrect placement of the cup. In 1997, for Ledoux, the cup should be placed centrally in the trapezium to provide implant stability. In 2011, Lucier noted 22% of cup malalignment of his patient of postoperative radiograph. The cup is the key point of the prosthesis, and the fluoroscopy is useful even for experienced surgeons. The study of Yori's doings suggests that the cup in the trapezium should be parallel to the proximal articular surface of the trapezium. The second study speaks about the inclination of the cup. We need to avoid a dorsal or a lateral inclination of the cup to avoid a dislocation. Example of an evolution of a bad cut. The cut is not parallel to the proximal articular surface of the trapezium, and the cup is not centered in the trapezium. The cup is too radial with an evolution to loosening of the prosthesis. An illustration of the publication of Bad Van Mierlo, the high percentage of loosening of the prosthesis by the man, especially the manual worker. A very late loosening of a Ledoux prosthesis after 26 years. Loosening was treated by an iliac graft and a touch. It's a case of Pascal Ledoux and Constantin Rossos. Small trapezium represents 75% of the failed prosthesis in the publication of Martin Ferrero and Brutus Kinen. The age of the trapezium has to be more than 8 millimeters. We have to be careful with the bone stock, the quality of the bone, and the presence of cysts in the trapezium. An example of a wear of the polyethylene by a manual worker, and periprosthetic ossification, new bone formation with subluxation of the prosthesis head and head cup dissociation. In conclusion, in the second generation, there was still a lot of early dislocation from 0 to 13%, often within 1 year postoperative, in direct correlation with technical error. The survival is from 90 to 96% at 5 years, and from 85 to 95% at 10 years. The third generation with the double mobility seems to solve the problem of dislocation less than 1%. There is still 3 problems: the loosening of the cup, the polyethylene wear, and the periprosthetic calcification. Thank you very much for your attention.
Thank you very much, Anne, for this nice presentation and for taking our attention on different technical points of this surgery. Now I call Mr. Van Mierlo for Ivory Arthroplasty of TMC1 arthritis in men, analysis of clinical outcome and implant survival.
Thank you for the introduction. I'm aware, of course, that the Ivory arthroplasty is out of use nowadays, although I'm convinced that the message of this presentation can be interesting in view of future developments of thumb-based prosthesis. So the question I would like to answer today is the failure rate higher when using an Ivory arthroplasty in men compared to women? We did the study, a single center cohort study in which all patients had isolated trapezium metacarpal osteoarthritis, and the postoperative protocol was the same in every patient. The first 3 weeks they got casts. After 3 weeks there was auto-revalidation, followed by the adjustment of a removable thermoplastic splint, no physiotherapy, no power grip, and after 3 months there was a resumption of normal activities in all patients. Our outcome measurements are clinical, range of motion, strength, functional, quick dash, pain score, radiological, of course, and qualitative. What is the patient satisfaction, aesthetics, and of course, survival rate. Between 2005 and 2012, if I'm correct, we collected 50 patients, of which 21 male patients and 29 female patients. And in the male group, 3 patients deceased and 4 were lost to follow-up. In the end, keeping 14 patients that were found eligible for inclusion. And this was good for 17 arthroplasties, since some of them had bilateral arthroplasties. The female group was in fact an historical cohort that was retrieved from a previous study performed in the same center and operated by the same surgeons and published earlier in the Journal of Hand Surgery. This slide shows the comparison of the clinical outcomes and overall function preoperatively and postoperatively in the male group of patients, and we see a significant difference in quick dash scores and pain scores. And in this next slide, the clinical outcomes and overall functions the clinical outcomes in the operated hand was compared to the contralateral hand at follow-up, and here there were no significant differences. This is an important slide. In this slide, we see the implant survival, and of the 17 arthroplasties in the male group, we counted 7 failures, which is a lot, while in the female group, only 3 out of 24 failures were encountered. Let's take a closer look at the male subpopulation. We had 41% of failures in the male group. There were 2 broken prostheses, 2 patients with polywear, and 3 dislocations of the cup. When we put these data into a Kaplan-Meier survival analysis, there was a significant lower implant survival in the male group compared to the female group. I'm going to show some specific cases. This is the first case of a patient that got bilateral arthroplasties and was pleased at a certain time in history, but he encountered a neck fracture on the left side and a cup dislocation on the right side. This is another patient, the patient that encountered extreme polywear, as you can see in the middle X-ray. This patient needed treatment, and he was treated by a trapeziectomy, after which he was pleased with the final result. So what surprised us most in this series is that 4 out of the 7 failed arthroplasties in the male group had limited pain and did not seek revisionary surgery after failure. And the common feature of these patients was the fact that there was hardly any difference in length between the proximal articular surface of the trapezium on the one hand and the distal articular surface of the metacarpal. In other words, the prosthesis of the CMC joint did not collapse. The arthroplasty seems to serve as a spacer. And if we take a closer look at literature, we see some analogy with failed arthrodesis, the patients where that are pretty happy once you take out the material after the arthrodesis failed. And there's some analogy too with the controlled pseudarthrosis as described by Rubinho in 2013. I think what all these patients have in common is that after removal of the hibernated subchondral bone,
elle fait pas tout le mouvement, quoi.
Attends.
So what I think all these patients have in common is that there's removal of the hibernated subchondral bone and there's provision of mechanical stability of a previously unstable joint.
Can you conclude, please?
Yes. So how can we explain the difference in behavior? between the arthroplasty between men and women. We think that the decline in muscle mass and consequential decrease in muscular strength that is seen in women with aging might increase the difference in, for instance, grip strength between men and women with aging. And we must not forget that in key pinch maneuver, as Philippe and Joris told us before, the cantilever bending loads produce a dorsal-radial force at the thumb metacarpal base that is over 7, 8, 10, maybe 12 times the force applied at the fingertip. So to conclude, what can we remember of this presentation? The Ivory arthroplasty in men, there's an important improvement in overall function and pain reduction as well. There's an important radiological failure in this series, over 40% within 5 years. And the incidence of radiological failure exceeds the need for revisionary surgery. Not all patients need to be treated when the prosthesis fails. Thank you very much.
Thank you very much for this presentation, Bert, that demonstrates that good indication gave the good result. I will not speak you about revision of trapezium metacarpal prosthesis by implant replacement. Thank you. Okay. So the two main surgical treatments for trapezium metacarpal arthritis are joint replacement and trapezectomy. As for all prosthetic surgery, there is a risk of implant loosening. When it happens, it's possible to replace the implant. After opening, the subcutaneous tissues are generally inflamed and often present black tattoos due to metallic wear debris. These tissues must be resected as carefully and as completely as possible. The metacarpal stem must be first removed, and this procedure is often delicate due to the risk of fracture of the metacarpal. The removal of the trapezial cup is generally easier. Once the implants have been extracted, a very careful curettage of bone cavities is performed to remove all inflammatory interposition tissues and the metallic and polyethylene debris that it contains. Cancellous bone grafts are then harvested generally from the distal radius. These cancellous bone grafts are placed in the metacarpal and in the trapezial cavities. The prosthetic components therefore sit on a bed of bone grafts that become compacted during impaction of the implants. If necessary, the trapezium can be reconstructed by using corticocancellous bone graft inserted inside the trapezium. In this case, temporary M1, M2 pinning must be performed in order to immobilize the first web space and in order to protect the cup from the axial stress transmitted by the metacarpal stem. In every case, a plaster cast must be maintained for at least 6 weeks to ensure integration of the bone grafts. We have performed 46 revisions of trapezium metacarpal prosthesis. The implant was replaced in 39 cases, while trapezectomy had to be performed in 7 cases because of excessive destruction of the trapezium. In one case of early dislocation with trapezial fracture, the trapezium was reconstructed with a corticocancellous bone graft. 15 DCD patients couldn't be reviewed, of course, and the mean follow-up at the time of evaluation was 40 months. The mean interval between the initial and redo procedure was 92 months. Both components of the implants were loosened in 33 cases, while only the cup was loosened in 9 cases and only the stem in 1 case. Redo surgery was performed for implant dislocation in 3 cases, corresponding to early dislocation in one of these cases. 17 patients were reviewed. 2 patients reported no pain, 2 weather-related pain, 2 pain on effort, and 1 patient reported rest pain. In terms of mobility, loss of retropulsion was observed in 12 of the 17 cases, but all the patients were able to place their hand flat on the table. The mean Kaplan-G score was 8, mean strength was 4.5 kilogram on the operated side and 5.2 on the other side. This is a patient 11 years after her first prosthesis. Excuse me. There is a loosening of the metacarpal component. You see the X-ray after the redo procedure, a new prosthesis after removing all inflammatory interposition tissues and the cancellous bone graft. This is the same patient 13 months after the redo procedure. There is a good bone graft and prosthesis integration, and you can note the almost complete mobility. The same patient with a follow-up of 8, 10, and 14 years. This is the case of early dislocation due to a bad orientation of the cup in the trapezium. We can see a proximal rupture of the trapezium, and after 1 month, the prosthesis dislocated and the external wall of the trapezium was broken. The trapezium was reconstructed by a corticocancellous bone graft. A new implant was inserted in the metacarpal and in the trapezium, protected by a double pinning between the first and the second metacarpal. On the X-ray after 8 months, the external wall and the bottom of the trapezium are reconstructed, and the mobility is almost complete. Apart reviewed a series of 6 trapezectomies following failure of total trapezium metacarpal joint replacement with a satisfactory functional result. But the scapho metacarpal 8 was reduced of 34%, and aesthetically 2 patients were disappointed and preferred the thumb before when the prosthesis was in place. So the predictable loosening of trapezium metacarpal joint, as for any other joint prosthesis, can be managed by replacing the implant by a new implant or by performing trapezectomy. We prefer implant replacement whenever possible, as in our experience, the functional results are almost as good as those obtained after primary joint replacement and better than after trapezectomy. Thank you. So I call now Nadine Nolvoet for the use of tendon allograft.
Yes, good morning, everybody.
Nadine, it's to you.
Yes, thank you. I'd like to thank Anne for the invitation, and I congratulate her for this organization of this online meeting. So I will talk about the results of tendon allograft interposition. As you know, there are numerous operations to treat osteoarthritis of the thumb. That means that no operation works for all patients. We have to find the right indication. Normally, we propose to our patients a total joint arthroplasty nowadays, but if patients don't want a prosthesis, sometimes they have reasons for that, then we propose a tendon allograft. Usually it's a fresh frozen tendon from the tibialis posterior. So the advantage is it's a very large tendon. You can make it thinner, it's long enough. You can do an interposition, you can do a ligament reconstruction or a sling procedure. Between 2006 and 2015, we operated 48 patients and we could evaluate 34 patients of them, 41 hands. It were 10 men and 24 women, and the mean age was 59 years. In 9 hands, total trapezectomy was done with tendon interposition and ligament reconstruction. In 12 hands, we did a partial trapezectomy and did only a tendon interposition, so no ligament reconstruction. And in 20 hands, we did a partial trapezectomy with ligament reconstruction. You can see the group of patients is not homogeneous, but it still can give you an idea about what you can get with tendon allografts. It can also be used after a failed total joint arthroplasty, so you can maintain the height. Of 34 patients, we could evaluate the DASH score, the VAS for pain and the satisfaction. And 23 patients came to the hospital for clinical evaluation, so we could measure the Kaplanji score, thumb abduction, and key pinch. And mean follow-up was 4.5 years. Mean DASH was 19. Most patients had a low VAS score, so mean VAS was 1.3, but only 83% were satisfied. Mean Kaplanji score was 9, mean thumb abduction was 56. There was one patient with an abduction of 0 degrees. I will explain that in the next slide. And mean key pinch was 5 kilograms. So also with tendon allografts, a high or a strong key pinch can be obtained. Unfortunately, we saw that a lot of patients needed additional surgery. So this is one example, a 33-year-old man. He had an infection. That's the only infection we ever had. We removed the tendon allograft and we didn't do anything else. So he had a simple trapezectomy, but the outcome was not good because you can see there is a loss of height and proximal migration of the base of the first metacarpal. This patient, he had, there's another failure, but it was the wrong indication. He had spasticity due to brain injury. And in that case, you should do an arthrodesis. Don't try to diminish the spasticity with a trapezectomy. So the abduction was 0 degrees, even after release of all tendons and muscles. Then we had another case, a man who had a partial trapezectomy, who had still pain, and then we did a total trapezectomy, and then also a tendon interposition, of course, and then he was better. Another man who needed additional operation was this 61-year-old man. He needed an operation for ST joint arthritis, and also he needed an MCP joint fusion. And he also complained about tendonitis of the flexocarpi-radialis. In this study, a lot of patients were lost to follow-up, but I still looked in their files, and there were 3 more who needed a revision operation that we know of. Again, a man who a partial trapezectomy did not seem well enough, so we removed additional bone of the trapezium. The same for a 66-year-old woman who and she was operated in 2008 on this hand with just palmaris longus tendon interposition with a good result. The X-ray doesn't look nice, but she had really good result. And then on the other hand, she had a tendon allograft interposition, but she also needed extra bone removal from the trapezium. And then this is a failed arthrodesis. She was operated in another hospital, and we did a partial trapezectomy and tendon allograft interposition, but also that failed. And then we did a total trapezectomy, but she had persistent pain, probably because insurance was involved. In the literature, there are no studies with the same technique as we used. There are 3 studies that reported results of fascia lata, allograft interposition, and 2 studies did not have any revisions. Only the study of spans is a little bit similar to our results. So in conclusion, tendon allograft is an option. The advantage is you don't need to harvest any tendons, but satisfaction rate is not so high as compared to prosthesis, and also the revalidation is longer. We did not study that, but I see that in my personal experience. And it's also, and it's not a prosthesis, but you still can have surgical revisions. Thank you for your attention.
Thank you very much, Nadine, for this nice presentation. And so I call now Fabien Mugondo for arthroscopically assisted Eaton Litter Trapezium Metacarpal Ligamentoplasty. Fabien, we listen to you.
Thank you. Good morning, everyone. So the third CMC arthroscopy can be performed for cyanovectomy, removal of all loose bodies, assistance of fixation of fractures, or treatment of CMC thumbs osteoarthritis, like debridement, ligamentoplasty, but also trapezectomy, total or partial, or also arthrodesis. The advantages of arthroscopy are the low morbidity, the quick function recovery, and also rapid resolution of pain. The arthroscopy of the CMC joint can be performed by using 3 different portals, 1R, 1U, and also sometimes 10R portal. Zhang showed that arthroscopically it was not so difficult to find some ligament like the anterior oblique ligaments. And we can find it quite easily, and also find the location of the peak of the metacarpal basis. The instability of the trapezium metacarpal joint is due to traumatic disruption or constitutional laxity, or also systematic synovial disease. But joint instability induces abnormal joint loading with degenerative change, and surgical stabilization is needed to reduce the risk of chondral degeneration. The trapezium metacarpal osteoarthritis is the second most common arthritis of the hand, and 1 woman in 4 in USA have this arthritis. The well-known Eaton Litter classification gives the 4 stages of this arthritis. The 4th case with associated scaphotrapezial arthritis. By using this classification, we can define an algorithm for the use of arthroscopic treatment for the CMC arthrosis. For the stage 1, ligamentoplasty can be performed. The Eaton Litter can be performed also. So the Eaton Litter is not a new procedure. It is an extra-articular ligament reconstruction that stabilizes the basis of the thumb by using a slip of flexor carpi radialis that is introduced in the bone tunnel and turned around itself and suture to the capsule. From the author, this procedure delays the onset of CMC arthritis. After the procedure, there is a temporary fixation of the joint with a K-wire for 6 weeks. But this procedure is not advisable for stage 3 or 4. There are some studies that describe the result of this procedure, as well as the study of Van Giffen, who performed on 18 patients this ligamentoplasty with good results. The procedure was performed in open manner with a good satisfaction rate. Lane also described 37 ligamentoplasties with a follow-up of 5 years with a good rate of excellent or good results also. If we found an improvement of pinch strength and a decrease of the pain, and in his series, 100% of the patient returned to previous activity. He deplored nerve lesions and also some adhesion of the tendon. This video shows that the stability can be assessed. Here we can see the landmark for the arthroscopic treatment, and we can assess the stability before the procedure. And once the bone tunnel is performed and the graft is passed into this bone tunnel, the only facts to put in tension the graft will stabilize the joint even before the next step of the procedure, as we can see here when we tow the ligaments, the tendons. I described the arthroscopic technique with a clinical case. It's a 44-year-old man who had motorcycle accident with a fracture of tibia and also the fixed finger and missed trapezium metacarpal subluxation. He had the fixation of his fracture, but the subluxation was diagnosed only 8 weeks after. This video showed the different steps we follow to reconstruct, to perform the ligamentoplasty. It was under axillar block, and we performed the harvesting of flexor capillary radialis and the 1U and 1P portals. The Cmc Joint arthroscopy was performed and start with debridement of soft tissue, and then the identification of the anterior oblique ligaments and the beak of the metacarpal. Then we can also assess the cartilage. Here in this case, we can see that on the trapezium, there is a focal stage 4 chondral lesion. After we introduce a bone tunnel guide on the beak of the metacarpal and perform the tunneling of the bone. After that, we introduce the slip of the FCR into its sheet up to the basis of the metacarpal, and we retrieve it on the ulnar side of the anterior oblique ligaments, as we can see now. And using shuttle relay suture technique, we are able to introduce this graft into the bone tunnel and to perform the ligamentoplasty. Here we can see that the tendon is entering into the basis of the metacarpal. It can slide at the beginning when we can adjust the tension of the graft. So after the fixation is performed with a K-wire for 6 weeks, the next step are the same of the princeps technique. This is the result of two weeks. And after the removal of the K-wire, we have the result here on the skin wounds at the 3.5 weeks and the functional result after 3.5 weeks. The patient was free of pain and show a good range of motion with a Kappa-G near between 9 and to 10, and good mobilization of the Cmc joint. The key pinch force was at 3.5 weeks, a little decrease in comparison to the control lateral sides. But When we saw again the patient after 20 months, this grip strength was increased. Like we can see here, the patient was still free of pain, and on the radiographic control, he does not show any involvement of the arthritis of the CMC and nor instability. To conclude, the Eaton Littler CMC joint ligamentoplasty can be performed with arthroscopic assistance. The advantages are that this dissection is less important, and there is a limited arthrotomy, and it's also an intra-articular assessment. But further studies are needed to assess the advantage on the functional result of this technique. Thank you for your attention.
Thank you very much, Fabien, for this very nice presentation of very technical procedure. And you'll speak us about arthroscopic partial trapezectomy with suspension by external fixator versus mini tie rope. Okay, go.
Thank you. So as I said previously, the trapezium metacarpal arthritis is very common, and Eaton Littler classification is well known, and we can use this classification to define the algorithm of treatment. The treatment may be conservative, but when the conservative treatment fails, then we can go to surgical treatments. The indication is persistent of symptom after 6 months of after conservative treatment, and for the stages 2 to 3 of Eaton Littler classification. So surgical treatment may be joint debridement or trapeziectomy or arthrodesis or interposition arthroplasty or also prosthesis. The Eaton Littler classification gives the basis for the arthroscopic algorithm, and for the Eaton 2 to 3, trapeziectomy with or without interposition can be performed. The arthroscopic portals are always the same. We can use 3 portals, and some author described this technique with without suspension, without interposition. As Hofmeister, we perform a Cyanovectomy, resection of half of trapezium, and thermal capsular plication, and then temporary K-wire fixation for 3 weeks, and then he used splint for 7 weeks. He described the result on 18 patients with quite good result, improving in the key pinch and the tip pinch also, and but he had 20% of decrease of range of motion. He had some complication like radial nerve lesions. Edward also performed a review of 23 patients where he performed this technique without interposition and capsular shrinkage. He observed that there was just a little migration of the metacarpal by 3 mm, and conclude that interposition was not necessary when doing partial trapeziectomy. Cox described the technique by using 2 buttons for the fixation and not a K-wire. He described that it's good, it's allow a good stability and provide early return to mobilization of the joint. In our department, we use minim X-fix for the fixation, and based on the concept of suspensioplasty, the X-fix is maintained is put to maintain the distance between the 2 bones, the time for the scar fibrous tissue come into this space and serve as a cushion. in combination with the sparing arthroscopic technique, it's allowed to avoid the use of casts. We keep the wrist free, and the removal of the X-fix is performed on the outpatient clinic. We use this technique on the basis of previous experience on the total trapeziectomy, where we keep the space with the mini X-fix. We perform previously a study on 19 patients that showed that the migration of the basis of the metacarpal was not more than 50% of in comparison to the LC size, even when we perform a pinch. On this video, we can see the different part of the procedure. We perform the arthroscopic. As usually, the beginning of the treatment is the cyanovectomy and debridement of soft tissue. Here we can see a stage 4 osteoarthritis of the trapezium, but also on the basis of the metacarpal. After debridement, we perform hemitrapeziectomy by using a burr to obtain a flat surface of the trapezium, and we can fix with either a mini tightrope, like we can see here, or by using mini fixation. The mini fixation is keep up to 6 weeks. Here we have the result of one patient who had the treatment for the both sides. We can see here that the range of motion is quite good, and the patient have a good decrease of pain. This patient, we can see here the X-ray. We have a follow-up of 3 and 4 years for the left and the right side. We can see the X-ray after this time of follow-up. There is a little migration of the metacarpal basis, but the patient still have good Cmc score and also good strength in grip and also pinch. Here, another patient, it's our first patient. We have a follow-up of 72 months. Here we can see the result after 72 months. The clinical result of this patient with the motion are shown here in this video. The Cmc score, it's at the left side, is 9. And even if there is a decrease of the pinch force, but the patient have a better score than on the other side. For the tightrope, our experience is quite limited because we just start in 2018. Here we have the result after 1 year. We can see that there is not a lot of migration of the metacarpal after 1 year. So other technique are used for after partial trapeziectomy, as well the use of interposition, as described here by Herb, who perform interposition of palmaris longus or flexor carpi radialis, a person. And he put a splint for 6 weeks after the procedure. This author described good results and with a good decrease of pain, and also some complications as with one complication with graft extrusion. Landstrom also described this technique with interposition of abductor pollicis longus or a part of abductor pollicis longus. He described that the harvesting and implantation is performed in the 1 hour portal. He keep the patient with splint for 6 weeks. The results are quite good with an improvement of quite 80% in the dash, but he described one case of neuropraxy of the thumb. There are contraindications of this arthroscopic treatment, like the scaphotrapezial arthrosis, metacarpal phalangeal hyperextension, and also Ehlers-Danlos syndrome. To conclude, there is a place for arthroscopy in the treatment of trapezium metacarpal osteoarthrosis, and most of open procedure can be adapted on an arthroscopic point of view. Theoretically, there will be a faster recovery and improve of outcome, but the sensitive branch of the radial nerve is at risk. However, there is no comparative study, and probably prospective randomized controlled trials should be done to evaluate the benefits of this procedure. Thank you for your attention.
Thank you very much, Fabien. And I call now Philippe Belmer for pyrocardon implants for the basal thumb surgery. My experience, your experience. Philippe?
You hear me? Yeah.
Yes.
Do you? Good morning, everyone, and thank you very much to Anne Lejeune and the Belgian Man Group for inviting me to speak about my experience with the pyrocardon implant. I have a conflict of interest to disclose. I will share with you my experience with all the manner to use the pyrocardon in the basal thumb, and also the future of this implant. The pyrocardon implant has been introduced 9 years ago. It's a free pyrocarbon spacer with two surfaces concave shaped, and the implant is rectangular shape, and it has only 1 millimeter of central thickness. Sorry, going back. For us, the main indication is this TMC osteoarthritis, and it seems logical for us to use this minimally invasive interposition with well-tolerated materials such as pyrocarbon, especially in early stages of osteoarthritis and in young and active patients. And in any case, it doesn't burn the bridges. This is a surgical technique. You can find it on YouTube. To summarize, I do a dorsal approach, and the aim is to make a remodeling of the saddle surfaces of each bone to a slightly convex shape, and then to interface the joint with the implant, which must cover completely the trapezium, and to suture strongly the dorsal capsule. No ligamentoplasty is required, and no restriction of using the thumb after 6 weeks. We have published, soon it's online on Head of Print, of our series of patients with 103 consecutive pyrocardon implant with a mean follow-up of 67 months, minimally 60 months up to 120 months. The series, there were 16% of patients less than 50 years old, 27% were manual worker, 83% had a stage 2 of Eaton-Littler, and 40% of the cases had first metacarpal subluxation. We had a very interesting result in terms of pain relief and function recovery, as you can see, over the time, and return to normal activities of work were an average 12 weeks and a little bit longer for manual workers. Mobility doesn't change because it was not impaired in these early stages, but the grip strength, the strength increased remarkably, especially for the key pinch and grip strengths. On the X-ray, metacarpal subluxation was completely corrected in 80% of the cases, and 8 remained minimally sublux and doesn't add any impairment on clinical results. There were no remarkable subsidence of the implant and no implant migration. There were 7 minor complications and 8 revisions for persistent pain. For these 2 cases had implant replacement for a bigger size, and 2 implants were removed to be converted with a trapezectomy. The 5-year survival rate was 96.2%, and you see the cumulative survival rate seems to be flat over the time until 120 months. There were similar results in the literature than ours, and the more recent is than those of Logans, who had exactly superposal results that ours. It's just published soon. If we look at the other procedure with long-term, over 5 years of follow-up for the trapezectomy, comparing our result, the strengths were lower. If we compare with the total prosthesis, there were a higher rate of revision complication rate, and also a higher, lower survival rate than ours. Looking at the patient less than of 15 years old, results looks a little bit better, and the overall satisfaction rate of all the series was 96% of patients very satisfied or satisfied. This is a typical case of a manual worker of 47, 8 years. You could return to work at 3.5 months, and you see the X-rays after 7 years and a very big pinch strength. For the STT osteoarthritis, I prefer to use the pirocardan rather than the STPI implant, because this implant fit better the shape of the STT joint, and the implantation preserves the distal scaphoid and the STT ligament, so that the scaphoid has normal kinematics with this implant. The surgery is made with an anterior approach. The aim is to get a slightly convexity surface of the trapezium on the trapezoid surface. And you can see that the scaphoid is able to glide normally over the implant. You can find also the technique on the YouTube. We have published the results 3 years ago with a mean follow-up of 3.8 years. And we had remarkable results on the pain and the function. And we have seen that there were over time, no carpal instability. In case of peritrapezium osteoarthritis with a good trapezium, we can use a double arthroplasty with pyrocarbon in the STT and TM joint. And we have a series of 23 cases, which are going to be published soon. And we have got some interesting results with this technique, only in case of if the trapezium has a good shape and a good bone structure. It's also interesting to treat this difficult problem of failed trapezectomy with the pirocardan. We have a series of 8 cases, also published online and ahead of print. We can do an interposition to avoid an impingement of the base of the metacarpal with the scaphoid of the trapezium. Another interesting useful use of the pirocardan, because of his minimally invasive arthroplasty, is to use it with other procedure like TM fusion. You can see that it's very not invasive, or also with arthroplasty of the wrist. This here with Amandis procedure, and you can do TMC arthroplasty or STT arthroplasty with this procedure. This is a future of the pirocardan with a thicker one for the treatment of this severe ZID deformity with complete destroyed trapezium. And the aim of this implant is to restore the length of the thumb and to allow a normal mobility of the thumb. We have done some cases with very interesting results, and we will publish it later after 2 years of follow-up. So in conclusion, the pirocardan is a minimally invasive technique. It's a reliable arthroplasty for TMC and STT joint. We have a low rate of complication at mid and long-term follow-up and high survival rate. And there is no contraindication if in case of subluxation of the metacarpal, and especially in young and active patients. Thank you for your attention.
Thank you very much, Philippe, for this nice presentation. We are a little late. Do we have time for questions?
There is one question, Pascal. Question from Constantin Rossas. Is there still a place for the STPE in the treatment of?
Joris, I have one question. When we reviewed our prosthesis, we have seen that in the literature, in the series with a higher rate of dislocation, the rate of loosening were decreased. We think that it's due to an more important stress when the ligaments are not cutted to explain the high rate of loosening. What do you think about it?
I think it's a good and a possible explanation, Pascal. So that's why I suggest that you advise to cut all the ligaments to have less strains and less forces on the prosthesis. But your study shows clearly the most dangerous period is the first weeks after surgery. Is that for you also the main indication to go to a larger head prosthesis? And do you see in your own experience then that you have less dislocations in the early period?
Okay, thank you.
I have a question for you. So I've cited your article about the myoprosthesis, but do you see now less dislocations with the larger head prosthesis?
Yes, we don't have dislocations. We have now agreed series with Bruno Lussier and Cyril Falaise, and we don't have dislocation of the prosthesis for more than 300 prostheses.
And you did not change the technique compared to your series with the Maya prosthesis?
No. I cut all the ligaments around the trapezium metacarpal joint.
Do you think there can be a place to remain, to keep the dorsal and palmar ligaments? Or
could you repeat? I didn't.
Do you think it could be possible, or do you see a problem if you retain or suture the dorsal and the palmar ligaments, because the center of motion for flexion extension is not changed between a normal joint and the prosthesis, and to give some more immediate stability?
Yes, it is. There is a change because we have two, in a normal joint, we have two axes of rotation, and with a prosthesis, there is no axis, but a unique center of rotation. But I think that no ligament are necessary after prosthesis if the tension in the thumb is good, is the length is good, and if the axes are normal, and it's not the ligament that stabilize the prosthesis.
You have any idea of how much lengthening you give to a thumb compared to the normal joints?
I try to restore the normal length. So with the M1, M2 ratio, 0.73 is a normal ratio. And that's what I try to have after surgery.
So when compared to the degenerative joint that you are going to do surgery on, you have some lengthening, but it's normal because you restore the normal length of the normal thumb.
Yes.
Okay.
Comparing to the situation before surgery, yes.
Okay.
There is a lengthening, but it's a restoration of a normal length comparing with a normal population.
Yeah, okay, it's clear. Thank you.
Joris, I must say that I am always suturing the capsule and ligament after surgery, at difference with Pascal. And as I use the dorsolateral approach, I do a L flap, and I also always suture. I don't know if it's better for the stability. I don't know. I don't think so. But for me, it's a precaution for, and I'm very happy to suture it. It may see if you are the correct length, because we have a suture point at the beginning, at the angle of the L, and if your implant or flap may be suture without tension, you know that you have good the good resection. Sometimes it's not always the case, sure.
In my experience, when I do also use the dorsolateral approach, I do a transverse capsulotomy, and before closing, I put some stitches on the capsule also to have an idea of the length. So if I can close a capsule, I didn't lengthen. When the capsule is open, I can do some push-pull of the head. Yes. But when the capsule is closed, I can check on fluoroscopy and it's completely stable. I can pull on the thumb. So that's why I asked that question, could it be a problem or not to suture or to keep the dorsal ligament? And also it's a barrier between the skin and the prosthesis against infection. Maybe that's also an advantage.
Yes, for me it's the case.
I agree with the fact that it's a barrier. But another reason for me to cut this ligament is that if you want to conserve the ligament, you have to cut the periost, and for me, it can cause calcification in the trapezium metacarpal joint after surgery, and we have I don't remember the percentage, but we had a lot of calcification, maybe due to the periost that remain in place. That's another reason for us to remove the ligaments and the periost.
Don't you think by removing the ligament, you increase the stress on the prosthesis, especially on the trapezium cup? Because the ligament also are useful to share all the stress all around the joint to the bone, and not only around the cup.
No, for me, cutting the ligaments decrease the stress on the cup, because if the ligaments remains in place, you'll have more stress on the cup because the kinematics of the joint have been changed, and with the ligaments in place, in certain positions, there is traction on the ligaments and an increase of stress at the level of the trapezium and the cup, at the interface cup trapezium.
In case of Ehlers dans l'os, hyperlaxity, do you have some suggestion for this kind of patients?
Yes, I send this patient to my enemy.
Another suggestion?